Afternoon, everybody, and welcome. Thanks for joining this webinar hosted by the Neurology Academy. We're going to be talking today about data and the dashboard, the National Neurology Services dashboard, a bit about accessing it and a bit about navigating it. You'll have, if you're interested in this topic, which obviously you are, you'll know that the lack of data and access to data, being able to easily visualize it, compare it to other areas, has been a real issue in neurology, and that's what the dashboard is all about. So we can use that data to transform services, and I'll talk a little bit more about that as we go through. For the purposes of how this is organised, so we have an hour, so we're on between 1 and 2. That's hopefully not going to be all me talking, although a big chunk of it will be. But can you please use the Q&A function within Zoom, so not the chat. If you leave things in the Q&A function, I'll hopefully be able to keep an eye on that, or at least come to it at the end, and we can have a discussion about anything that crops up through the talk. A little bit about me, for those that don't know me. So I'm a neurologist based up in Cheshire Merseyside at the Walton Centre. I've been there for nearly 20 years as a consultant there, and from a clinical point of view, do quite a bit of MS and related conditions, as well as general neurology. I've always had an interest in leadership and management and service transformation and so on. I've been a clinical director there for 10 years or so, and digital lead CCIO for them, as well as Cheshire Merseyside ICS. They don't hold any of those roles anymore, but have been working as a clinical advisor to NHSE's Neurosciences Transformation Programme for the last couple of years, and still doing that, and so have a role as deputy chair in the new National Neurology Clinical Reference Group, so assisting the National Clinical Director. This talk partly came about from this meeting that we had early this year in Birmingham. It's a national transformation meeting, and this is just a shout out and plug for the next one. It was a very successful meeting, and there's another one planned. So if you can save the date in there in your diaries for anyone that's interested, so 29th of January next year. Again, it's going to be in Birmingham. We don't know exactly where yet, but yeah, please put a pencil that into your diaries. And also, this is just a note, you don't need to read everything that's on this screen. This is really about the on-demand service offered by the Academy. So the meeting that we held early this year is available through the Academy on their on-demand service. And anyone who wasn't able to attend, I'd strongly encourage you to have a look through that. And in particular, if you're thinking about attending the next meeting, I think you'd find it really useful to look through the content of the previous meeting. So please do have a look at that. And finally, as asked by the Academy, just to give a shout out for this. So this is something offered by the Academy, and is online course and content about wellness for healthcare professionals. Obviously, quite a frequent topic of discussion, but still something neglected by many of us, I think. So the Academy have done their bit here with developing some content about this, as well as all the other stuff they do. So please do have a look at that. Thank you. Let's start with a few slides, some of which will be slight repetition, but hopefully not too much before we dive into the dashboard itself. So I've talked a little about why we have a neurology dashboard. I think that is a bit of a no-brainer and self-evident. In terms of how it's put together, this was this came out of the NHSE service transformation program. Myself and others, I think, really pushed for this as a real blank space and gap in what we had in terms of access to data. And to be fair to NHSE, they really took that on board, and the data science team in particular. So in particular, Emily Jones now Richard Birch done enormous amount of work putting that together. And obviously be very glad to take you through that and show it to you in a bit more detail very shortly. Who's it aimed at? A pretty wide audience, really, but I suppose it's anyone that's interested in neurology services, and in particular improving services, transforming services, and knows about the power of data. And if you don't know what you don't know, you really don't know what to do and how to change things. So it's certainly for clinical directors, service leads, neurology service managers, commissioners, as well as sort of regional commissioning teams and the national team. I'm going to talk a little bit about how you access it in a bit more detail, because I know it's not entirely straightforward. We can't, partly because it's an NHSE developed thing. There are certain confidentiality parameters we need to stick to. We can't just publish this openly. I personally would quite like to do that. It's all public data, but we're not able to do that. So this is hosted on the NCDR, the National Clinical Data Repository. Many of you will know about that, have access to it anyway, because there's all sorts of things on the NCDR. But you do need access to that, and for that you need an Okta account, which again, if you've accessed other things like Model Hospital, you will have one. But if you don't have one, if you go to the NCDR portal, there's an opportunity to register. That's a QR code for the portal, by the way, if anyone wants to use that. I'll be going to this page when I start navigating through the body, so you watch me sign in and see what happens. But a bit about the registration. Once you've registered, the first time you log into the NCDR, and I apologise, this is a very wordy slide. The first time you go in, you do have to add some details. You have to create a profile that includes something about you, about your organisation, what roles you've got, and you need to select some of the groups that you're interested in, and you've got to select some of these in order to be able to, at least one of these, to access the dashboard. They're fairly obvious when you go through the ones that you would tick anyway, but these are worth sort of just making a note of, or at least a couple of those that you think you would use. Just make a note of those. The next step, again, has caught some people out, I think. So it asks you to put a line manager or an authorizer. It's best by far if you don't put your local line manager, because they are probably not going to have the relevant permissions to be able to give you access to this dashboard. The easy thing to do there is to email the Service Transformation Programme team on that generic email there, or at the moment specifically Richard Birch, and his email again is there, and tell them that you've requested access. They'll be able to go in and grant that very, very quickly as soon as you do that. But if you just put your own local line manager, things will sometimes just stop at that stage, and you'll wonder why you haven't got access to the dashboard. Once you've done that, when it's been approved, you'll see on the top of your screen that reports are then there, and then you can choose reports that you're interested in and add them to your favorites, or what they call your pot. And then they're there whenever you log in. They're right there. So it's all very straightforward. Once you've done that slightly not straightforward process. And viewing reports is pretty self-explanatory, actually. That's pretty straightforward. So I'm going to stack those slides, and so this is just a browser page on the NCDR portal. So this is what you see. So I'll actually show you what happens here. So I sign in. So I've got the adult dashboard. I've also got the separate multiple sclerosis DMTs dashboard, which I'll touch on as we go through. And then you just select that you want to view it. and then you're in. So this is the dashboard. So the landing page is this overview tab. So if you look at the top here, there's various tabs that you can go through. You can navigate those with those two big arrows at the top. Those just navigate you through these tabs, or you can just click on the tabs as you run the browser. So you land on this overview page, but just worth noting before that, there is a cover sheet which just gives a little bit about the ownership, purpose of the report, date it was last published and refreshed, and so on. There's also a link here to a survey form where you can give feedback about content or suggestions, and you'll see that actually on several different tabs. But that's something we do want people to feedback and give either ideas and suggestions or other feedback. The other tab here, which is again perhaps in the important but dull tab, is about the dates of when this has been refreshed and what's recently been added, which is actually quite useful to know. So this is the current release and when the next release is planned, and that's a very important feature of this dashboard, is that it is refreshed. So we've had data in the past and reports like the GIRF report, but they've always been static, and by the time they're published, actually significantly out of date. One of the really nice features about this is that it's continually refreshed, mostly on a quarterly basis. So this is the landing page. So this shows a heat map, which I'll talk a little bit about, and a selection of the metrics. So there's lots of metrics in the dashboard, but this is a selection of the top 6, if you like, that we thought give you a sort of headline overview of some stuff that's happening in your ICB. This section here is where you select which ICB you're looking at. Obviously on the map you're looking at all of them, but these data apply to that. It's alphabetical, so it always defaults to this one, NHS Bath and North East Somerset. But if I select my ICB, it should automatically refresh, and you'll see all the data change there. So this is now Cheshire and Mersey ICB, and that's highlighted on the map here. And this defaults to, on the heat map, it defaults to non-elective admissions, so adjusted per population. So that's this metric here. And all these show each ICB. If you hover, they'll show you the individual ICBs and their data. But the line is obviously the median. Where we are is the blue dot, so you can immediately see if you're about average, above, below, and so on. And in the background of the card here is a trend over time, and it'll show you which quarters those apply to. If you want to change what's showing on the heat map, you can do that either by this drop-down box here, or when you're on the actual card here, if you just click the map icon there. So this is now for percentage of patients seen within 18 weeks for an outpatient appointment. So the map now is showing that. And obviously the lighter the color on the map, the lower the value. Some things are good if they're low, some things are bad if they're low, which is usually self-evident. So this is so that's the landing page, what we call the overview. If you go to the next tab, so this is called Neurologists and Providers. So this is a mixture of data about how many neurologists there are, and that was gained from the GMC data via a freedom of information request, interestingly. So this is as accurate as we think it can be, but probably not completely accurate, but it's probably the best we've got. So it shows you the number of neurology you've got, again, per population, and what your population is in that in your ICS. And this is probably worth pointing out that this juncture, we're talking a lot about data for an ICS or for an ICB. I'll use those interchangeably, but the reason it's you might say, well, why ICS footprint? Many of you will know that neurology has been one of the services delegated to, rather than nationally specialised commissioning, most neurology services are going to be delegated to an ICS level footprint for commissioning. So it makes sense to look at it in this way, even though in some areas, in many areas, the existing neuroscience service footprints will not obviously closely match what an ICB footprint will be. And that's sometimes apparent when you're looking at the data, and I'll touch on some of that later. But this is for your ICB. This data, so it shows you the something about how many neurologists you've got, and you can just for fun look at other areas that where you think you can see they're relatively low. Some of that's unsurprising in Cornwall, and where it's very extremely high, which again is unsurprising in central London. This here also shows you something about your providers. So these are the acute trusts in your patch, and they're color coded according to, if you hover over, it'll tell you what they are, and they're color coded according to the GIRFT classifications, which is this N1, N2, N3, N4, N5. Which, if you're not overly familiar with that, I wouldn't really worry too much. But green means visiting neurologists only, so you don't have employed neurologists at those sites. And again, we can talk a bit more about that as we go. So let's go on to our next tab, which is called summary. So all the metrics are here, and there's some summary data about them. So the actual figure for the latest year and for the latest quarter, you can show again where you are benchmark wise in terms of other integrated care systems, and this will show you some SPC variation. If you're not familiar with SPC charts, there's a very sort of a simple key down here about what the different colors and arrows mean, but green is good and red is bad, basically. And how this is split on this page, if you look on the left here, so obviously you've selected your ICB, and again you can change ICB very easily if you want to do that, but it's split between inpatient and outpatient metrics. So it's defaulted to inpatients. Please select outpatients. Again, this will all change, and it will show the relevant outpatient metrics. You can also look at research. So research, the data we've got on research is limited, but we did want to include. So if you do that, obviously you've got to choose a condition. So we did want to include something about clinical research because I'm sorry, the importance of it and of good places tending to be involved in clinical research. This is limited to studies that are registered on the sort of national databases. So this isn't by any means all research. So some of that is a bit limited, but we thought it was important to get it in there. I've now toggled back to outpatients, but I'm still on a condition. What you'll notice when you do this is that, let's change that to epilepsy now. When you're in outpatients, if you want to look at something condition specific, you're quite limited in the metrics that are available. And that's because we don't code outpatients in neurology, which is a big problem. Something I hope we can tackle in the longer term. But although we look at activity in outpatients, and there's lots of data on that and how quickly people are seen, we don't code it, so we don't know what conditions people have got. So there's a few specific things that we can measure. So here, for example, rates of valproate prescription in women of childbearing age. But for the stuff that's coded to conditions, you get much more for inpatients, because inpatient admissions get coded. So you can look at different metrics there, or just change it to all neurology. if you move on up to detail, so the difference here is that you can select any metric that you want to from the whole list. So again, this is defaulted to non-elective admissions of any duration. And again, it still stays on the same ICB. And this is for all neurology. And this just shows you the detail of that over time, how you compare to the national average, again, over time, here on an SPC chart. And you can see here in a different way where you rank with different ICBs and where the mean is. So Cheshire and Mersey are relatively high for this metric for unplanned admissions. If look at outpatients seen within 18 weeks. So now being higher up on this list is a good thing now. So we're relatively good for that, 73%. But again, you can look at all these metrics in this way and see where you compare with other areas. And you can look at this, how it's changing over time. A lot of these, so this one is, you can immediately see the impact of the pandemic, where lots, the percentage of people we were seeing within good time frames dropped dramatically and recovered, and then has dropped again as we and everyone else struggles with the backlog. Just to show another example again, if you switch that to Valpray, it reminds you to click a condition for this, although that's the only condition we're interested in. And again, this shows you where you are and highlighted, but on the map you can actually quite easily see that data for other areas, and you can see that in bar chart form, and you can see the trend over time. So again, relatively high actually in our ICS, but moving in the right direction. So the next tab is about inpatient admissions. So this essentially gives you a list of providers in your patch, and a bit about their size. So the size of the bubble here is proportionate to the number of spells, and you'll note, so the Walton Centre, for example, here looks quite big. So, but this is all activity, all admissions. If you just look for non-elective activity, you see a different picture. Obviously, so for tertiary centres like Walton, there's a lot of elective and planned activity, a lot of day case activity, but the non-elective acute neurology happens at other places. This is Arrow Park Hospital on the Wirral, Wiston Hospital, and so on. And this on the right, you can see who those providers are, and you can see what's being admitted to those places. So for unplanned admissions, headache is always the number one, usually followed by epilepsy and seizures. That's a recurring pattern. There are two centres here, East Cheshire and Mid Cheshire Hospitals NHS Trust. This illustrates one point that I talked about earlier about ICB geographies and neuroscience footprints. So for my patch, if you like, these two, we've never provided services to those hospitals, so we would often consider them not in our patch because they have a relationship with other neuroscience centres in North Staffs and in Manchester respectively. But because we're looking at this on an ICB footprint, for the reasons we've discussed, that these will show up on the data. So that sometimes makes things look unexpected if you're thinking about your normal patch, which we'll come on to a bit when we talk about flows. So again, as I say, you can split this to elective and non-elective, and you can look at what conditions are being admitted and where. Related to that, next part is called acute inpatient liaison neurology. So this is about liaison neurology, so acute neurology ward consultation services, which is how a lot of neurology care is delivered, of course, in non-neuroscience centres. So for this, well, you need to select an actual provider that you're interested in. So let's look at Mersey and West Lancs, so what we call Wiston Hospital. Again, this is sticking with my ICV, but you can change that and all this data will refresh. This is looking at all neurological conditions. So this is by what's coded. And you can look at some detail about the metric, how we define those metrics and so on in some of the later tabs, which I'll show you. But this essentially shows over time. So each of these bars is a quarter. And this shows how many people are admitted with what we call core neurological disorders. The definition of that, again, it's all in the dashboard, but this is essentially mirroring what Gerft looked at, looking at conditions that would, definitely be considered core neurology, and in theory would be, if it could be delivered, would be better off under the care of a neurologist, even though they're usually not. So this gives you an indication of the demand for liaison neurology or for neurology beds, if that's what you want to deliver. So that's core, and then there's other. So you can look at that in both ways. And if you hover over that, it shows you the number, also shows you the percentage of what that is compared to all the other acute stuff that's coming in. So it hovers around 10, about 10 to 12% usually, which is about right, probably mirrors what we'd expect to see. This here shows the percentage that are under the care of a neurologist, which for this trust is unsurprisingly 0, because there's no inpatient neurology beds at this hospital. And at the bottom here, this just displays this in the sense of, on average, how many beds would be occupied by those patients with core neurological disorders. Not everything, just the core neurological disorders. So in a sense, this shows you, if you like, if we had a neurology ward or half a ward, what would we need in number of beds, which I think is quite a nice way to look at that. And obviously you can split this for individual conditions if you want to. If you're looking at non-elective activity, usually you're probably going to look at all of it, but you can split that absolutely if you want to. The next section is about flows. So this is flows into and out of your ICB, and you can I'll show you how we flip between the two. You can again include all activity or just day case activity, non-elective, outpatient first, outpatient follow-up. So this shows quite nicely in a nice sort of visualization about what's happening within your own borders and what's happening outside. So here, we've got 20% of events occurring outside of your ICB. If you hover over that, it'll show you the numbers and where they're going. And you can see that here as well. So most of these are going to North Staffs and Greater Manchester ICB. Now that sort of data might show you exactly what you expect, but it might show you some things that are suggesting there's a problem in that there isn't a service available within your own patch, so they're having to go elsewhere, and you probably need to look into your own data in a bit of a sort of more granular way to look into that. I, for example, would look at this and say that that's what I would expect, and would anticipate that these are patients, for example, from those trusts and those areas that are in the east and the south of the ICB that have always had a movement and flow and relationship with those other the neuroscience centres in those other ICBs. That's probably exactly what I would expect. You can this is looking at activity, by the way. You can flip that to look at indicative cost. So this, certainly if you're looking at from a commissioning point of view, this is what this shows you the cost of that activity, and therefore you start to think about flow of money and who's paying for these with the new models of finance for ICBs. This is really useful. Those you can actually I won't actually show you this, but if you press on this, you'll actually get a page where you can actually change those indicative costs. So these are based on averages, national averages, but some areas, of course, have negotiated different tariffs for this or for that. So you can actually put those in and change those yourselves, and then that will adjust all this data for you. So, but we'll go back to looking at the activity. And again, so that's out of ICB. So if you flip that into ICB, again, this will refresh. And this shows you it's obviously a very different picture. So so this shows that there is a fair bit of stuff coming in from outside of ICB. Most of it now, actually, this is from Lancs and South Cumbria. And that probably is for reasons to do with areas of that patch that, that have not had good service or they have very long waiting times, that sort of thing. So again, there's different reasons why you would look at that data. And you can look at the indicative cost of that, and then you can start to think about well how you might want to change planning and delivery of services. And again, you can look at this for different for your because this will be very different for inpatients. Obviously, non-elective inpatient activity will tend to land whatever you do locally, and so this is probably more relevant for some of the elective work, some of the elective inpatient work, and certainly for outpatient activity. But you can toggle that in and out of this data as you wish to look at that. Again, this comes back to this issue partly about the difference between the ICS footprints and the currently existing neuroscience footprints, and we don't necessarily need to change those. In some areas, those are fine and they're functioning, but it's the ICS's responsibility to make sure their population are getting a good service. So as long as they are, it doesn't matter if they're provided by a different ICB. But if these are showing that there is actually a problem, there are black holes where people are not getting a service, or there's lots of people going out of ICB, you can start to ask the questions why, and reorganize services accordingly. The next habit is specifically about MS, disease-modifying therapies. Now, and this one is slightly different in that because there's quite a bit of data there. This shows you just an overview of that, but it takes you to a different dashboard, so it's held separately. And this is partly because there's been a specific work stream looking at MS DMTs for reasons that are probably obvious to everyone, but they're quite expensive, and it's also something that's recorded and something that you can measure because all these prescriptions are done on a national system, BlueTech, and the costs are all in a national delivery base called SLAM. So we've got a lot of data there. So I'll briefly show you through this. So this looks at so these are different ICBs, how many patients are on DMTs, what percentage of that is per the population cost, and then something about what percentage of people are accessing that outside their own ICB, and also something about and translating that into actual travel time. So part of the focus of this was about access to treatments, and we know from previous data, including GIRF, for example, that your chance of accessing DMTs, and certainly specific DMTs, the higher efficacy DMTs, is proportional to how close you are to a neuroscience centre or neurology centre, which obviously isn't right. So we wanted to put in this metric about showing distance travelled and time to travel for patients accessing services in different areas. You can split this by standard efficacy and high efficacy treatments, which again runs through the thing, runs through this particular dashboard. So again, this shows it in a sort of heat map form, and you can change the metric that you're looking at. That's the total of patients who are accessing DMTs in different areas, and you can see there's a lot of variation there. You can look at that in terms of percentage of people receiving the high efficacy DMTs, which again starts to look a bit different, but again quite a lot of variation. For example, you can look at areas where there are patients accessing DMTs outside of their ICB. And again, sometimes that might be exactly what you'd expect, but quite often this is telling us that there are areas where there's a lack of service and therefore they're less likely to access that sort of treatment. So the areas here, which are probably not surprising that some of those are familiar with services and how they're organised. This shows the split between high and low efficacy, high and standard efficacy treatments. So the dark blue is high efficacy treatments, light blue is the standard efficacy treatments. So obviously we're not going to go through this in detail, but we can see there's obviously a very different split in different areas. Some of that will be explainable and for very good reason, but there's quite a lot of variation there, which is probably telling us something. We've got some disability data because that's recorded in BlueTech, which I'm not going to go through in detail today. But there's also some demographic and equity of access and ethnicity and deprivation data, which I think is quite nice. This is the first sort of attempt at doing that within the dashboard, or something I think there's a lot of interest in doing more of. So this is showing access to DMTs, but splitting it in terms of, for example, index of deprivation. So you can look at the difference in percentage of DMTs, if you look at the bottom right here, by your most deprived parts of the population. So 15% are on DMT. To your least deprived, it's 22%. So a significant difference. This is nationally, and then you can look at that for your own ICB. So Mersey. That refreshes, and so actually 28% in the most deprived. And then 21% in the least deprived. So that's showing a slightly different pattern, which is probably telling us something good about the service there. But these are the sort of things where it's giving you information that you then need to do probably a sort of deeper dive in more granular data that you have locally. And again, you can look at this for ethnicity as well. There's a bit on the dashboard about delivery networks, as in where services are and whether they're a prescribing site or not, which again, for purposes of today, I don't want to go into too much detail about. And in fact, what I'll do now, I think, is go back to the main dashboard. To my home ICB, and so then the next few tabs are really not about more information, they're more about the dashboard. So a bit about methodology. So some of this stuff, some people are not interested in this at all, but this certainly if you're looking at your data and you see something that looks a bit odd and you're trying to work out whether it's giving you an important signal or there's something odd about the way the data has been collected, you can look at the definitions here and the methodology. These are all the data sources. We're displaying data here that is already collected, but the problem is it's all in different places, not readily accessible, certainly doesn't have nice visualization tools over it. What the dashboard doesn't display is some things that we would really like to measure, but are just not in the sort of standard reporting systems at the moment. So how many ward consults are you seeing per week, for example, and the outpatient coding. It doesn't work like the stroke snap database, for example, where the onus is on the provider to actually submit a lot of data, which is extremely useful, although it's very resource intensive. Whether we can move to that model in part is unclear. I think it would be useful if we could, but at the moment this is working by just displaying lots of currently available data, but just in a very sort of collating it all in one place and with a nice visualization tool over the top and benchmarking, which I still think is very valuable. There's some definitions here about what the metrics actually mean. So some of them are really sort of self-explanatory, but some of them actually aren't, but they're all in here, the definitions. There's a couple of tabs after that. I'm not going to go into any detail today, but where you can actually download data. So you can download data from this and import it and play around with it yourselves. If you've got local data, you've got your own BI tools that you want to use, so you can do that from this dashboard. And that is probably all I wanted to show in terms of actually navigating you through the dashboard. Let me come back to my slides and sum up, and then I'll come to the Q&A. So I just want to thank the Academy for arranging and putting on this talk. You're all familiar with the Neurology Academy, I'm sure, because you're registered here. I wanted to mention again, through the dashboard in various locations, there's a link to an MS Forms form to give feedback and suggestions. So encourage people to please use that. If people are interested in getting involved in the dashboard, we do have a user group that meet regularly, but not frequently, to talk about issues with the data, issues with the dashboard itself, what's planned for future iterations, and so on. I currently chair that, so that's my email there, and you can also email the transformation team on that same email that I mentioned earlier, and that is the QR code again for the NCDR portal, and I will stop sharing that. So there's a question about posting the link. I can certainly share that. Yes, yeah, I can. Now these slides they'll all be available afterwards. The presentation, and we can certainly put some links on that in a slide or so with the steps about registering, and also about who to email for the line manager. There's a question about how is this different from the model health system. It's a different platform. So the NCDR, so we had some discussions originally about whether we would use model health as the platform for this, or NCDR. There are various pros and cons of that. We went with NCDR. There is some stuff on model health about neurology. If you look at it, I've not looked at it in a while after, but it's pretty limited. And we just thought NCDR was better for various reasons. So that's why it's they're just different platforms. Can this data be accessed by the third sector? The short answer to that is no at the moment. I think you do have to be NHS, and some of that is intentional and deliberate. Some of this data, if you're working for a pharma company, for example, you can obtain, but for a fee, which is probably fair enough. Some of it is open source and you could get anyway. So some of the prescribing data, for example, but you can't have access to the dashboard on the NCDR, I don't think, unless you're actually NHS, and that has been an issue with some people that we would actually like to give access to, but haven't been able to. Condition. I think we talked about that during the. So it's a question. We don't code conditions in outpatients. So lots of specialties don't do that. There's a few specialties that do that. Most specialties don't actually code outpatients, but it's a particular problem. I agree in neurology, where we're a very outpatient-based specialty. There's been a lot of work done about coding in outpatients, and there's an ongoing work going on, which includes the ABN as well as the transformation program. Headley Elmsley in Lancs has been heavily involved in this and trying to get a fairly straightforward and user-friendly list that you can use. The trouble with coding in outpatients is it's time consuming. however you do it, whether you do it on paper-based or you get it in an EPR. If you're embedding it in an EPR, you've got to embed it in 25 different EPRs. So it's not straightforward. Some areas we have developed, we have a system for coding our patients at Walton, for example, so we do it, and I think other places do, but there's no sort of nationally agreed platform for doing that and submitting that data. And I hope we can do that. I've talked about access. Yeah, sort of bear with me when I look through these. Can you access what people that have actually been admitted to hospital with? So that's a good question. So not so this isn't within the dashboard. So obviously we know that there's been a non-elective admission, and we know that they've been coded in their sort of secondary or tertiary diagnosis as having pre-existing MS. That data is there because obviously they're coded, so usually be UTI or chest infection, for example. But that's not in the dashboard, so we'd have to add that as a sort of more granular layer. I think that's a good suggestion, or something you would have to do locally, with your own sort of BI team. But that's something I can certainly take to the user group. Final question. Since the dashboard is fantastic, so thank you very much. So how does it being utilized? So I think the point you make is partly about shining a light on neurology, which is a big problem. So it's been delegated to an ICB footprint of commissioning, but most ICBs, a lot will have the approach that they've got bigger problems. Neurology is relatively small compared to others, but it's also viewed as being a bit sort of esoteric or exotic and a bit special. And I think one of the things we're trying to push with the whole transformation program is that neurological conditions are actually not rare at all. A lot of this is so specialized neurology perhaps is a bit niche, but even that, a lot of those MS is not rare. But if you look at particularly the non-elective, the acute side, headache, seizures, suspected stroke, about 3/4 of people admitted to stroke units have conditions other than stroke, and a lot of those are neurological. So if you look at all that, it's actually very common, and it's occupying a lot of bed space, occupying a lot of resource. So part of this is actually trying to just shine a light on that so that you can get neurology a bit higher up the pecking order, get a seat at the table when we're having conversations with people in ICB settings. That's the hope anyway. We'll wrap up there. So thanks very much for those who submitted questions there. I hope I've dealt with most of those or did as we went along. As I say, this will be available after from the academy, and we can add in some extra information there about on some of those topics. But thanks very much for taking the time for joining. I hope that's been useful. Please do try and access the dashboard, even those people that we know who've had some problems doing that. Please email me or the neuroscience team on that email address that was on earlier if you're having problems with that. And please feedback on the dashboard, and anyone that's interested in being in the user group, again, please get in touch. Thanks very much, and enjoy the rest of your day, everyone.